Great. Thank you all. This looks certainly like a quorum, so I'll just very quickly say my name is Lisa. I've interacted with all of you over email. When you email the squawk@chiamass.gov, that is very frequently me or my colleagues, Isha and Scarlett, are at the email. So thanks for joining us today, and I am going to hand it over to my Executive Director, Andrew Jackma, to kick us off.
I didn't hear that last part.
I think Lisa meant to say she was going to turn to Andrew, if I can read her lips correctly.
Great. Thank you, Michael, for the interpretation. Good afternoon, everyone. My name is Andrew Jackma. I'm the Acting Executive Director at CHIA, and it is my great privilege to welcome you all to our inaugural meeting of the Statewide Quality Advisory Committee, which we shall affectionately refer to as the SQUAC. We'll go through more of the history later in the meeting, but very quickly at the top, the SQUAC was established through one of the significant healthcare laws that was recently enacted in Massachusetts, Chapter 343 of the Acts of 2024, an act enhancing the review process. And under Chapter 343, CHIA is responsible for convening the SQUAC, which will be led by our co-chairs, David Seltz, Executive Director of the Massachusetts Health Policy Commission, and Commissioner Michael Caljo of the Division of Insurance, with the broad goal of advancing quality measurement alignment for value-based contracts, consumer transparency, and a variety of applications of quality measurement. More specifically, the goal of the SQUAC is to ultimately provide CHIA with recommendations regarding an aligned measure set for mandatory use in global budget-based risk contracts in 2027 and 2028. And, as I think about it, this goal and the work of the SQUAC really reflects a long-standing priority for the Commonwealth of reducing fragmentation and misalignment in quality measures, both to cut down on administrative burden and costs and to help keep our quality improvement efforts tightly focused. So to that end, the SQUAC will be building on previous efforts in the Commonwealth that have to date been coordinated through the Commonwealth's Quality Measure Alignment Task Force, or QMAT. And the QMAT will be serving the SQUAC in advisory capacity for the next few months during a transitional period. And I think we'll be getting more into the specifics of that dynamic later in this meeting. So finally, for me, just a quick housekeeping item. I should note that this committee is subject to the Commonwealth's open meeting law, and that meetings of the SQUAC and all related subcommittees will be live streamed on CHIA's YouTube channel. They will be recorded and made publicly available, along with all related meeting materials on CHIA's website. Committee members should have all received an email with information about the open meeting law. But if you did not receive that email, or if you have any questions, please don't hesitate to reach out and we will get you squared away. And with that, I will turn it over to our co-chairs, beginning with David Seltz, Executive Director of the Health Policy Commission.
Thank you so much, Andrew, and good afternoon, everyone. I'm David Seltz from the HPC, honored to co-chair this new SQUAC, and yes, there will be a pop quiz on all of the acronyms that you will hear today at the end of this meeting. I'm really, thank you all. First of all, just thank you for participating in this and for serving the Commonwealth in this role. I understand that you've all been sworn in for these important appointments. And I'll just say, from the HPC's perspective, we're just really excited about the formation of this group as part of the significant healthcare laws that were enacted last year, and really excited about the opportunity for partnership with Commissioner Caljo, the Division of Insurance, CHIA, and all of you as we begin this critical work. I see a lot of familiar faces as I look around this Zoom room, and some new faces as well. And so we're really excited to work with all of you. We have in Massachusetts a really proud history of robust multi-stakeholder engagement in support of many activities, but as Andrew mentioned, a history here on quality measure alignment. And I think, as Andrew said, and as we'll talk about, this really is building on a strong foundation. We have years of work of doing this through what was the Quality Measure Alignment Task Force, QMAT. And so this is really about taking the next step forward in promoting that administrative simplification and measure alignment for the goals that were mentioned before. And I'll just say that, we're launching this work at a really critical moment for the healthcare system overall, recognizing some of the headwinds that we face in terms of challenges to our system, known that we'll be facing some coverage losses due to federal changes, the financial challenges that face our workforce, the fact that our workforce is burnt out and overburdened. And we've been working on and talking about some of these issues in the primary care task force, which I'm also honored to co-chair. And so I do see an incredible amount of opportunity for all of these different activities to come together to really make significant progress. Reducing administrative burden and focusing quality outcomes, improvement efforts, that has been something that's come up in the primary care task force. I see some members of the primary care task force here today. And I think this is really the group that is going to be able to make significant progress on tackling this issue because of the right level of kind of expert input, the technical expertise that is a part of this group. This is really a great group to make progress on this particular issue. And I will also note, and please excuse me, the alignment, so to speak, of this work with the governor's recently announced healthcare affordability work group, which is also going to be focused on issues around promoting efficiency and promoting better health outcomes. So I'm excited to begin this work, and I'm really grateful for all of the years of work that led us to this place. This work was really led by the Executive Office of Health and Human Services prior to this new formation. And I want to recognize Lauren Peters in her role when she was at EUHHS, and more recently Eliza Lake at EUHHS for their significant contributions over the years to this work. So with that, I'll turn it over to Mike Caljo for some opening remarks.
Great. Thank you, Director Phelps and Director Jackma, for your opening thoughts. I'll be brief. I want to just kick things off by, first of all, joining in those remarks and mentioning our alignment as agencies to the work ahead. I think our task is all about alignment and efficiencies. Part of that is also aligning government actions, and we have a responsibility to do that in a concrete and transparent fashion. And you should know that the Division of Insurances and me as Commissioner of Insurance are dedicated to that agency alignment to our work ahead. I like to think about this as the return of Squawk. It's like a Godzilla movie because back in the day, Squawk preceded QMAT, and now QMAT begat now Squawk again. We have, I think, a lot of good momentum, and I really want to say thank you to the group that has been a long-standing set of members offering advice and counsel to that prior work and to this new work ahead. We really will do well if we listen intently, understand the impacts of any potential recommendations. And that impact is not just on the institutional players, not just providers and hospitals or health plans, but also on the patient. For me, my perspective is going to be really motivated by understanding the benefit that we can take towards patient care and having that as a driving force behind our actions moving forward. But just wanted to say that we at the Division of Insurance are foursquare behind this work and really want to get things going. So thank you.
Thank you, Michael. I think as we kick off this work, we want to first have an opportunity to have all of the members introduce themselves, and so we can get to know each other a little bit and introduce this group to each other. So I'd like to, I'll kind of call on people to introduce themselves. Please just introduce yourself, your organization, your position, and if you happen to be part of the previous QMAT, if you could please reflect that as well. So I'm going to start with the appointed representatives, and then I'll move to the state agency representatives. And this order of how I'm reading this out is based on kind of the statutory language. So you might say, why are you starting with this one? But that's what it's for. So Pat Noga, I'd love for you to start.
Hi, everybody. Pat Noga. I'm from the Massachusetts Health and Hospital Association. I'm the Vice President of Clinical Affairs, and I have served, I am still serving on QMAT.
Thank you. Kristen Ells.
Good afternoon. I'm Kristen Ells. I'm from the Edward M. Kennedy Community Health Center in Worcester. I'm also representing the Mass League of Community Health Centers, and I am their Director of Population Health and Clinical Quality.
Thank you. Barbara.
I think I'm the only Barbara on.
Yes,
I'm
sorry.
Barbara Spivak. I'm representing the Mass Medical Society. I am on QMAT as well, and have been on it for a very long time. I'm also, I'm the past president of the Mass Medical Society. I'm the past president of an IPA, Mount Auburn Cambridge IPA, and I'm a practicing internal medicine primary care doctor at Mount Auburn. Thank you.
Thank you. Silda Mello.
Hi, everyone. I'm Silda Mello. I am past president of the American Nurses Association of Massachusetts, also the director of care management for a Massachusetts-based health plan that primarily serves the Medicaid population. I'm here representing an RN practicing in a patient care setting. I've been a nurse for over a decade, focusing on ambulatory care, primary care, and care management. And I am not on QMAT, but I look forward to taking on this work with all of you.
Great. Thank you so much. Dan.
Yeah, hi, Dan Mullen. I'm a clinical psychologist and the behavioral health representative in the group. I provide patient care in primary care practice in Barre in central Massachusetts. I'm a professor in the Department of Family Medicine and Community Health at UMass Chan Medical School, where I direct a center focused on the integration of primary care and behavioral health services.
Thank you. Ahmad.
Hello, good afternoon, everyone. My name is Ahmad El Musa. I am the VP of Quality and Compliance at Aspire Health Alliance. Been at Aspire for about 3 years now, and I am a member of QMAT as well.
Great, thank you. Dr. Freeberg.
Hi, I'm Mark Freeberg. I'm Senior Vice President, Performance Measurement and Improvement at Blue Cross Blue Shield of Massachusetts. I've been a member of QMAT since late 2019, and I am a general internist. I practiced primary care part-time for a little over 20 years at the Brigham. No longer see patients. Thank you very much.
Thank you. And Renee, great to see you.
Hey, I'm Renee Nefesi, and I'm the Director of Provider Quality at Point 32 Health, which is Tufts Health Plan and Harvard Pilgrim Health Plan. And I'm also the MAP representative to this committee and have been at QMAT and SQUAC participant before. So I do know the history if anyone wants to know.
Great. Thank you so much. Mark Mandel.
Good afternoon, everyone. I'm Mark Mandel. I am a practicing general pediatrician part-time up on the North Shore in a big general pediatric practice. Currently, I am the Chief Pediatric Medical Officer at Revere Health and the Medical Director for our Medicaid ACO. I've been in practice for more than 40 years and have had a number of administrative positions initially in the Partners, now MGB network. I've been at Revere now for 8 years. And I guess Steward first and then Revere. And have the pleasure of being able to represent pediatrics on this group. I've also been a member of QMAT for more years than I can count, I guess. And also I'm on the board of MHQP.
Excellent. Thank you. And rounding out our appointed representatives, Dennis. Great to see you, Dennis.
Thank you very much. My name is Dennis Heafy, and I'm from the Disability Policy Consortium here in Boston, Massachusetts. And I guess I'm representing consumers, patients. I'm a member of QMAT. As I'm sitting here and I'm looking at the names, the titles, everyone engaged in this process, I wonder whether my involvement is actually nothing more than a bit of tokenism, and whether or not the voice of the individuals who are being served is really going to matter. So I'll be taking very much a listen and learning position right now, but I'm going to have to be won over because it's very much, as it's assembled, very much an industry-driven group. So I very much need to hear from folks that this is actually going to be something that's geared towards and focused on improving care for people in the Commonwealth. Thanks.
Thank you, Dennis. And I think I can speak for Michael Caljo and I when we say that all the voices of this committee will be valued and really want to have input from everyone. So thank you and look forward to working with you. Would now like to turn to some of our state agency partners who are going to be joining this work. As Michael said, alignment across state government is going to be an important part of this, as well as input on some of the policy. So we'll start with Beth Lucas.
Good afternoon. I'm Beth Lucas. I'm the acting commissioner for the Department of Mental Health. I've been with the department for 20 years, and my first role in the department was as the director of quality improvement from 2006 through 2015. So at that time, I was on some version, whether it was Squawk or the predecessor of Squawk, but I have a paper file somewhere that I could dig out and look at my notes and handouts from those days.
Thank you, Beth. And Kate Fillo, great to see you, Kate.
Thanks. Great to see you as well. I'm Kate Fillo. I'm the Director for Healthcare Strategy and Planning and also the Chief Clinical Officer at the Department of Public Health. Thanks.
Thank you. And Linda?
Sure. Hello, I'm Linda Shaughnessy. I'm the Senior Director for Quality at Mass Health. I've been there for about 9 years. I've been part of QMAT in the beginning, the first 5 or 6 years, and I work closely with my colleague who is serving the QMAT currently. So super happy to be here and part of this great group.
Thank you. And Whitney, great to see you, Whitney.
Good to see you as well. Hi, everyone. I'm Whitney Moyer. I'm the Chief Operating Officer for the Executive Office of Aging and Independence. I was not part of QMAT or the original Squawk, so I am new to this group, but not new to this work, having worked at a SCO and One Care health plan as previously Vice President of Long-Term Services and Supports and Clinical Provider Integration, and previously Mass Health Chief of Long-Term Services. So glad to join.
Great, thank you. And Lauren?
Hi, everyone. This is Lauren Makishima. I'm the designee from the Group Insurance Commission. My title is Data Analytics Manager, and I've been following the work of the QMAT for the past few years, and very committed to aligning with the recommendations and incorporating them in the work that the GIC does as well. Thanks.
Great, thank you. And Barbara?
Hi, David. So I'm Barbara Fain. I'm the executive director of the Betsy Lehman Center for Patient Safety, which I like to just mention. We are in fact, a state agency, the only one named after a person. I was not a member of the QMAT, but I was on the previous SQUAC in its last 2 years. So good to see everyone.
Thank you. And Elizabeth Daly, did I miss you in the first go around? I'm so sorry.
That's all right, David. Elizabeth Daly. I'm a lead analyst with 1199 SEIU, and we are a labor union representing healthcare workers in hospitals, nursing homes, community health centers, and doing home care. And I hope I'll bring a voice representing the workforce, whether it's for training needs or whatever other impacts we might be seeing on the workforce as we go forward with this work.
Great. Thank you so much, Elizabeth. And did I miss anyone else? I don't think so. Okay, well, great. We're going to move into our agenda for the day. And as we just heard, this is a really interesting and robust group of experts. Some of you are so steeped in the history of the first iteration of SQUAC and then QMAT and now this new version. And then there are some of us here who are really coming into this new. So we did want to spend part of our day here today just really trying to level set for all of the members around some of this history, around some of the progress that has been made, and also about what our new charge is going to be. And I think the absolute best person to help guide us through that history and our charge moving forward is our longtime facilitator and expert project manager on this, Michael Baylett. All of you who have been part of this project know Michael very well. He has been so valuable for the progress that we've made, and we're so grateful that he's agreed to continue on in this new iteration and helping us do this work. And so, Michael, I'm going to turn it over to you and to help us run through our agenda today.
Thank you, David. Thanks for your kind words, and good afternoon, everyone. I'm pleased to have the opportunity to work with you as we set sail on this new quality measurement adventure. So I'm going to give a brief overview of the charge that the SQUAC has. I'm going to do a one-page history, but I think most of you now have some familiarity with it. I'm then going to review the current aligned measure set that the QMAT recommended last year for use this year. And I'm going to talk about the annual review process that it has undertaken historically and is currently actually right in the middle of. And then I want to share what were some of the goals that the task force developed for activity for this year. And in so doing, I want to ask you whether you have any objections to continuing with the work that group recommended. And of course, about half of you are from the task force. So you will have an opportunity to share that experience over the course of today's meeting and in future meetings.
Michael, just let you know, we're seeing the presenter view right now.
Oh, okay. I can never remember how to move from the presenter view. Hide presenter view. Okay, there. Thanks, Matt. And actually, let me introduce, for those of you who don't know him, Matt Reynolds is my colleague who has been supporting the work of the task force and will be supporting the work of the SQUAC as well. Okay, so quick on the origins of the aligned measure set. The Quality Measure Alignment Task Force was convened by EOHHS in 2017 in partnership with the HPC, Mass Health, DPH, and CHIA. And at least partly in response to input from Barbara and others at the Mass Medical Society who were talking about the burden that practices were experiencing because insurers were using all different measures in their value-based contracts. And so it was convened specifically to design an aligned measure set for global budget-based risk contracts, also known as ACO contracts. So very specific application. The objectives at the outset were twofold: reduce administrative burden for provider organizations, and two, focus provider quality improvement efforts on highest priority opportunities within the Commonwealth, and hopefully thereby generate improvements through that focus. The aligned measure set has always been for voluntary adoption by payers and providers. That being said, the level of adoption in the Commonwealth over time has become very high. The leading purchasers in the state have committed themselves to it, and really, with the exception of the national insurers, we have very good fidelity to the aligned measure set today. So your work stems from Chapter 343, which is about a year old now. Chapter 343 mandates the use of a standard quality measure set. We're going to continue to use the word aligned measure set because it's well established, and also because it doesn't have the acronym SQUIMS. So we're going to use aligned measure set, but I want to note that while this builds off of the current QMAT aligned measure set for global budget-based risk contracts, and makes compliance a legal requirement as opposed to voluntary, it does some other things that are new. It broadens the application of aligned measures to all provider value-based contracts. We're going to have to figure out what that means and how to operationalize it. It requires the aligned measure set be applied for insurers that have products that tier their provider networks. We're going to have to figure out how to make sense of that. And then 3, it requires public reporting of performance. So all 3 of these bullets are activities that are beyond the scope of the current Quality Measure Alignment Task Force.
And Michael, sorry to interrupt, but
it's okay.
On that first point of broadens application of aligned measures to all provider value-based contracts, the previous QMAT was really focused on global budget based value contracts, and so this goes beyond that. So potentially, and this will be a conversation that this committee will have, that could include bundled payments or some other type of value-based payment arrangement or payment contract is
specialty contracts. I will say the task force has on multiple occasions in the past talked about whether it should expand its work to hospital measures, and for good reasons has elected not to do so historically. So there are a host of different provider types that have contracts that might be value-based, for which conceptually you could develop an aligned measure set. I'll note that in Rhode Island right now, they have 4 different aligned measure sets. They actually had as many as 6, but right now they have 4. So we'll have to discuss where we think there would be added value to creating new aligned measure sets in order to achieve objectives that might be those 2 that the QMAT adopted or other ones that you all want to adopt. The law calls on CHIA to convene this body to make recommendations on the measure set. For 2026, which is a transition year, as David indicated earlier, the QMAT is going to continue the annual review process that began this past fall and will bring recommendations to this body in April. The QMAT will then sunset, and CHIA will procure a new technical advisory group that will serve an advisory function to the SQUAC. So it will be like QMAT. It will have the opportunity to be a larger body because the QMAT is much bigger in membership than the SQUAC is. So it provides an opportunity for more voices. And that procurement is something that will follow, I'm presuming, this spring or summer. There's also a change in governance and leadership. So the QMAT's been chaired by the EOHHS secretary, and recommendations go to the EOHHS secretary. For the SQUAC, as you now know, the DOI commissioner and HPC executive director are the co-chairs, and the recommendations go to the CHIA executive director. So most of these agencies have been involved in the activities of measure alignment, but the specific roles are changing. And finally, I'll note that QMAT has had a monthly meeting schedule every year, typically fall through June. The statute calls for the SQUAC to meet just quarterly. You all can decide if you want to meet more often, but the statute specifies 4 meetings a year. Finally, the statute directs that the SQUAC update the aligned measure set only in even-numbered years. That's different from how the QMAT works, where there's an annual review of the aligned measure set. The task force staff have discussed this directive because there are changes in measure endorsement by national bodies. National measure stewards change their specifications. CMS can change their requirements of mass health. And so we've talked about the possibility of having a more limited review in the off years of the aligned measure set, and then using the off year to focus on other aligned measure sets, tiering, and public reporting. But this is for all of you to talk about in future meetings.
Yeah, I just say I think that makes a lot of sense, because I think 2 years is too long of a time period to go without that dialogue, but we can talk about it more.
Yeah, and I should have noted also, sometimes clinical guidelines change.
Yeah.
And so we want to be cognizant of that, because we don't want to have measures that reflect guidelines that are out of date.
Sure.
Okay, so I'm going to give you a review of the current aligned measure set. So this is for contracts between payers and providers in ACO contracts for 2026. So the aligned measure set has 2 component elements, a core set and a menu set. The core set represents measures that all payers and providers are expected to use in their global budget-based risk contracts. The menu set is a list of optional other measures that payers and providers may choose to supplement the core measures with, but they don't have to. And the number of measures from the menu they select is totally up to the payer and the provider organization. The task force has also tracked measures in 2 other sets titled monitoring and developmental. The monitoring set represents measures of high interest to the task force, but for which performance in the Commonwealth has historically been very high, and where there is no meaningful opportunity for further improvement. Those measures traditionally have been tracked, and if performance does decline, then the task force has considered and actually has added them back into the aligned measure set. The developmental set is both a set of actual measures and measure concepts. So these are ideas that are of high interest to the task force members, but the measures aren't ready for prime time for one reason or another. Maybe they need to be tested. Maybe the measure specification has a problem and we're going back to the measure steward to ask them to make a correction. Or maybe we have not been able to find a valid measure, but the topic itself is of such high importance that the task force has wanted task force staff to periodically do a scan to see if there are any new measures that would meet the criteria of the task force. Okay, so when we say aligned measure set, the actual meaning in practice has been a little more nuanced. So here is the 2026 measure set. The core measure set consists of only 4 measures. And because there are only 4, I want to highlight what they are. So CG CAPS is a patient experience survey. It's a survey specifically for clinical groups. That's the CG and CAPS. And it's a version of the survey that was adopted by Massachusetts Health Quality Partners for use in Massachusetts. So it's not the national one, but a slightly revised version. Then there's one pediatric preventive measure, child immunization status. This is the full complement of immunizations kids should have, including the flu vaccine, which we debated heavily this year. And then two chronic illness measures, controlling high blood pressure and controlling blood sugar for persons with diabetes. And this is actually a measure of the percentage of the population of people with diabetes who have poor control. There has been recently a fifth measure, which is depression screening and follow-up plan, but the task force last year recommended transitioning from one version of the measure to another one. And so for a 1-year time period, those two depression screening measures are in the menu set, but with the intention that for 2027, one of them will be promoted into the core set. So that would be at least 5. We have, I believe, had as many as 6 in the past. The menu set is much larger at 21. So this is a mix of preventive measures and chronic illness measures. I want to note a few things as you look at this. One is there are a couple of measures here, 18 and 19, that represent a new prioritization on health equity that the task force adopted following the murder of George Floyd. These are really measurement infrastructure measures because we can't measure stratified performance right now because we don't have standardized collection of demographic data by providers and plans. And until we do, we can't at scale do stratification over all of the demographic variables we'd like to do. There are also a number of measures in here focused on behavioral health. The task force has struggled to find behavioral health measures aside from depression screening and follow-up that have large enough denominators so that they're viable for use in a payer ACO contract. But you'll see we have a few of them here. We also have struggled as a task force with finding maternal health measures, and there are a couple of those here. So I want to call those out just because those are topics that have been the subject of special discussion and task force effort over time. And as I noted earlier, we've got 2 depression measures here right now, 9 and 20. One of them will move up into the core set for 2027. The other will be retired. So the annual review process in the past has generally started late in the fall. This year began in December with recommended modifications to the measure set finalized by May. You might say, why May? It's in order for payers and providers to know what the measures are because they are often readying their contracts for the next calendar year in the spring and summer. And so this gives adequate advance notice. When we do conduct an annual review, we as staff provide a lot of information to the members of the task force. We let them know whether the measures in the aligned measure set had any substantive specification changes. Did they change their status change in state or federal measure sets? What's the level of adoption by insurers in the state? The HPC and CHIA do an annual survey of insurers to ask them which measures they're using. And we also look at opportunities for performance improvement by benching against national performance on the measures. We also look for opportunities to improve equity by looking at stratified performance on the measures as data are available to us. This is the timeline for the annual review for this year. Right now, we are right in the middle of reviewing the existing measure set. We're talking about the menu measures right now. We will begin in February to talk about new measures. And then, as I said earlier, we'll try to wrap up the review in April and come back to you with recommendations. And then the task force will meet again in May if your feedback in April requires additional processing by the task force. I mentioned earlier that there are criteria that are used to select the measures. These have been developed and refined over many years. In fact, we just made refinements a couple of meetings ago. They are defined at both the individual measure level and also at the level of the measure set as a whole. So these are the criteria for individual measures. Some of them speak to the measurement validity of the measure. So number one, does the measure correlate with improved patient health? That's a basic threshold question. Is the measure valid? Number two, is it appropriate for use in an ACO contract? Four, getting at measurement burden. Can it be generated without extensive burden specifically for providers? Or would the measure reduce burden by supplanting an existing measure with greater burden? Or is there burden, but it's justified because there's such a high beneficial impact on patient health that it's worth it? Five is there's an opportunity to improve population health, so we haven't, quote, topped out the measure. Six, there's an opportunity to improve health equity. And seven, the measure is being used. So there's a criterion that if the measure has not been used within the Commonwealth in the last 3 years and nobody's committing to use it in the following year, it should be removed. We have a couple of criteria if we're looking at a measure that's not been endorsed by a national measure steward. Most of our measures come from the National Committee for Quality Assurance or from CMS or another national body. But occasionally, we're looking at a measure where there's a gap. And so these are the two criteria. If there is no measure from a national body, yet the task force has felt that the topic is so important that we should have a measure in the measure set. And then there are criteria for the measure set as a whole. So one, the task force has wanted to prioritize health outcome measures. I will note that is much harder to do than you would think. Two, that the measure set provides a holistic view of an ACO in terms of population, age, and sex. So we've got a mix of pediatric and adult measures, measures specific to men and women as appropriate, and measures that touch upon primary care, behavioral health care, and chronic illness care. Three, we strive for parsimony. That's to reduce burden and improve alignment. The bigger the measure set, the less the alignment, especially with regard to the menu set. 4 and 5 are about ensuring that the measures would promote value and promote high quality care. And 6 is the topics and measures address opportunities to promote health equity. Finally, we have criteria specific to the core set. They are currently that there should be no more than 6 in number. It should be outcomes oriented. At least one should focus on behavioral health. That's our depression screening and follow-up measure. Universally applicable to the extent possible. What does that mean, extent possible? Well, if you have a pediatric ACO, the blood pressure control measure won't be appropriate. Or a maternal health measure might not be appropriate. 5, crucial from public health and health equity perspectives, and then 6, enhancing value. So as I had noted, these were developed initially in 2017, but have been refined multiple times since then. Any questions about the current aligned measure set or the process that the task force has followed? Again, I recognize half of you know this very well, and maybe even could have provided the presentation instead of me. But for some of you, this is brand new. And for those of you who are brand new, I want to give you the opportunity to ask questions.
This is Elizabeth. I'm wondering why no more than 6 in number?
Great question, Elizabeth. We debated this criterion only recently at a meeting. There have been some members of the task force who have said that they want flexibility so that they can pick measures for contracts that address a particular opportunity for a particular provider organization, because performance varies by organization. And so some payers have said, look, if I have an organization that really needs to improve in an area that everyone else is doing well in, then I want the flexibility to be able to include those measures. And the larger the core set, the less space I have for adding in those discretionary measures. Dan, I saw you raised your hand.
Yeah, thanks. Two questions. On this slide, number 3, a measure focused on behavioral health. Is a substance use, does the opioid measure count as a behavioral health measure?
Yeah. I mean,
Okay.
it would.
Yep.
In truth, we've never had more than one behavioral health measure, I don't think, in the core set.
Okay.
And we have struggled with behavioral health measures. The IET HEDIS measure has caused much hair pulling over time.
Yep.
We have a number of measures who think that the measure is not valid, but nobody wants to get rid of it because we haven't been able to find a better measure.
I'm on the hunt.
Okay.
I know it's a hard hunt.
Yeah, it is a hard hunt. Yeah,
going back 3 or 4 slides, there was an item that said like measures are appropriate for use in I don't remember every word.
Yeah, global budget-based risk contract.
Can you give an example of a measure that is inappropriate for use? I'm trying to wrap my head around the word appropriate there. So I'm coming the other way. Like, what's an inappropriate measure?
Yeah, that's a good question. I don't think we've ever pushed on that parameter. I'm sure that I could come up with an example, but in fact, I don't think that criterion has ever been put into use.
Okay. I have some ideas that might test that boundary, but
yeah.
I will wait.
Yeah. Okay. All right. I saw a couple other hands up.
Kate.
Go ahead.
Kate Phillip.
Oh, I was going to respond to Dan just from experience sitting on the QMAT. I think for behavioral health measures, we've looked at both mental health and substance use measures and continue, I think, to look for ones. But certainly, I think just as reflective, maybe more in trying to take a holistic approach. And so not just focusing on, like physical health measures, but really looking at population health and patients' health holistically.
Okay. Anybody else?
Michael, I think it would be helpful. Oh, Beth, please.
Just one other comment on this topic. Dan, I'll join you in the hunt for behavioral health measures. I do think it's important that we take a deeper dive into the existing universe of behavioral health measures.
Beth and Dan, we can share with you, and actually with everyone here after the meeting, all of the behavioral health measures that we have had in the aligned measure set and have removed from the aligned measure set because they weren't being used, usually because the payers told us that the denominators were too small. So we'll let you see the long sorted history of our quest to find good behavioral health measures.
Great.
Okay.
Happy to dive in. Thank you.
Barbara.
Thank you. I think one of the problems that we've always had with behavioral health measures is not just that the denominator is small, but we try to get measures that are not going to impose a lot of complicated requirements and more clicks for the physicians, particularly for primary care physicians. And many of the behavioral health measures just aren't things that you can get easily from an electronic record electronically. They're much more nuanced than that. And so they don't meet that criteria of being readily available data. It doesn't mean that they're not really important, but we just don't have a really good way of measuring outcomes in behavioral health. And the example I always use is that for years, we use things like PHQ-9s. And I would feel like, my God, I got somebody's PHQ-9 down from 25 to 20, but I would fail. Or they've had their whole life a PHQ-9 of X. I can't be responsible as primary care for getting it down. So I think the measurement of success in behavioral health is not something that you can easily get out of an electronic record. And that's been one of the barriers to getting better metrics in that area. Thank you.
Thanks, Barbara. Yeah, it's all very true.
Thank you. Mark.
Yeah, thank you. I have a question. One of the, in my opinion, really valuable contributions of the QMAT beyond the aligned measure set is the implementation guidance that accompanies the measure set each year. How will that be included in the SQUAC process? And the reason I bring that up is there are in the measure selection criteria, one recent change we made was to move the small denominator, / measurement reliability criterion over to the implementation guidance, because that's not really a property of a measure on its own. It's a measure as implemented, because measure denominators can change quite a bit from provider group to provider group.
Yeah, it's a good question, Mark. It's not something that we've discussed yet, but you are right that it's a very important complement to the aligned measure set.
Yeah, thank you for raising that, Mark. I'll make a note of that. We'll have a plan. Elizabeth. Sorry, Elizabeth, you're on mute.
Thanks. I'm wondering if any dementia screenings are widely recognized as valuable, and if they've been included or considered. There's any background on that?
Yeah, thanks for the question. So I should have noted this, but when we focused on the aligned measure set work to date, we focused on measures that are appropriate across commercial and mass health populations. But for the mass health populations, we've really focused on measures that are appropriate for the commercial health age population. So measures for older adults have not found their way into the set, because to the extent that there are value-based contracts that are being affected for older adults, those are more likely to be Medicare measures. And we have talked in the task force about asking CMS to join us at our meetings and to aligning their measures with ours. We actually got really close last year to having someone from CMS agree to come and regularly attend our meetings, and then they were told that they had been directed not to do so. But I think that's the reason why, Elizabeth, that a measure like dementia screening hasn't made its way into the conversation so far.
I can't make my hand go down. I don't know.
Well, Elizabeth, feel free to just come off mute if you have another point. Oh, you got it. Michael, I think it would be helpful to go back to the slide with the timeline, because I think it's important for us to, as a group, just kind of think about what the next 6 months looks like, as we're also going to be thinking about making plans for the next 2 years. Because we're, as someone who's coming into this a little bit new, for us new folks, we're really jumping into a middle of a process, and we do have to make a decision, really this spring around a recommendation to CHIA on the aligned measure set. And so, as you said, Michael, the QMAT has already been working on developing or helping to make a recommendation to us at the SQUAC to make a recommendation to CHIA on what the aligned measure set will look like for this cycle. You kind of said you're already kind of in, I think, row number 2 here in review of the existing measure set, moving on to consideration of new measures. And then in April, we'll come to this, we'll have a meeting of the full SQUAC to look at those, and if we need to have another meeting. But once we make that recommendation to CHIA, and if CHIA accepts that recommendation, that will be the aligned measure set for contracts in 2027 and 2028, correct?
Correct.
And so we will be kind of engaging in this cycle process again, really in 2028, going into contracts for 2029 and 2010. Am I kind of thinking about the calendars right?
Yeah, roughly.
Okay. So we do have, as I said, jumping in here, and I guess my recommendation is, as I've been thinking about some of these criteria and the process that has been used, I think for this cycle, my sense is that we should generally be relying on this tried and true process. But we may, as a group, elect to think about, are there changes to this cycle review process that we may want to implement the next time around that we're doing this. And so that would just be how I've been considering this. We have, a timeline ahead of us. We need to be able to move forward. There's been a great process that has already existed. Let's leverage it now, but also be thinking about how we might want to think about how this cycle could be improved upon in the future or changed upon in the future. What some of those criteria that Michael just walked through, how we might think about those could be amended or changed. But we'll have some time as a group to think about that leading up into the next review cycle. Renee?
So this might be a technical question on regulation, but a question is this about contracts that already have quality that needs to follow this mandated set? Do they have to, is it about an open contract? As you create an open contract with a new group, you have to make sure they do this. So my real question is, do I have to if I have a 3-year contract and it had measures different than this, do I have to change it and open that contract? Or is it just open contracts in that year that I need to put quality in? And if there's no quality in a contract now, is that okay? So I know that in other states, it's been, if you have quality, you need to have these quality measures, but you don't have to maybe open a contract. But if you don't have any quality, that's okay. Those are sort of regulatory questions that I have, and I don't know if they've been thought through or answered, but do I have to open a 3-year contract with the new rules? And do I have to put quality in a contract that doesn't have it?
Yeah. So I'll take a shot at this, but please add on to this, Michael or David. The traditional approach has been that there's not a requirement to open standing contracts, but it would apply on a rolling basis moving forward to contracts that are negotiated subject to the time in which the recommended sets are put in place. I think because of the nature of and complexity of both the provider side and the insurer side, I find it hard to believe we would upend that historical process, but please jump in if folks disagree.
Yeah, Mike, I've seen it done both ways. In Rhode Island, they require that the aligned measure set be used every year, even if they're in the middle of a contract. But the approach that you've just described is also common. I'm not talking just about for measures, but for insurer requirements in general.
And I just want to add Tory standpoint, since CHIA, we have our draft reg posted for public comment now with relation to the standard quality measure set, and it ties a lot of details like this to sub-regulations that's still forthcoming. So Renee and others flagging concerns like that and sending questions, send them in emails. It's really helpful. And we will make sure that sub-regulatory guidance clarifies exactly those kinds of details.
Thank you, Lisa. Before we move on to the next agenda item, Michael, did you want to share?
Yeah, let me just jump in and say I have a pre-existing conflict, so I'm jumping off. I'm going to be aided in our discussions by Kate McCann, who's listening in on this conversation, and she's our Deputy General Counsel. So I just wanted to note that and thank everybody for their work. So.
Thank you. Mark? Sorry, Mark. Yeah,
that's okay. Got it now. I'm just curious as to whether there are, Ray, if you're aware of any contracts in the state that don't have quality as part of the global value-based contracts. Because that part of the question wasn't answered. I mean, maybe that will come out in the regs, but I'm not aware of any contracts that don't have quality as part of the contract.
We do have contracts that don't have quality as part of our contracts. Not ideal, and it might be a small group in a small situation or a small population, but certainly there are contracts that don't have quality for one of our products. And as I said, I'm hoping we don't have to open new contracts. So obviously there's a lot of work that goes on in all negotiations. So want to make sure that we follow all the guidelines, but not have to open things again.
Thank you.
Okay.
Michael, let's move forward and review again some of the work that's been ongoing with the QMAT.
Okay, I just have one last topic to share, and these are the goals that were set by the task force for its work in 2026. They actually were developed last year, but I should note as context that in addition to the annual review, there's a lot of related work that's done. For example, those of you who are task force members know this, and those for whom I provided an orientation know this, but the task force has also been the entity that has developed and maintained health equity data standards for payers and providers in the state. So that's data standards for race, ethnicity, language, disability, sexual orientation, gender identity, and sex. And so there's work done to make sure that people are educated about them and to encourage adoption. There's work that's done on specific technical issues like how to facilitate transition to electronic measures, because quality measurement is moving to electronic-based measurement. And so I'm going to share with you on the next slide the goals that were developed for this year. And my real question is, do you want to support the momentum in these areas, and are there any objections? So just 5 goals. The first one is to complete the review on time and to incrementally increase the size of the core set to strengthen alignment. The task force did not agree on exactly how large the core set should be, but there was agreement that increasing the size by some increment was desirable because it would strengthen alignment. 2, they recommended action to develop and implement a health equity data standards dissemination and education plan, because 2025 was a year in which 2022 standards were reviewed and updated. And so they were updated for implementation in 2028, but there needs to be some communications messaging about the new standards. So that's number 2. The task force has been working for a number of years on measuring and reporting on ACO quality performance, not knowing that the new statute was going to require this. And so we've had some struggles on figuring out how to do this. And so the third goal before the law was made law was to go back to working with payers and providers on a methodology for doing this. 4, advance health equity through collection and reporting to the SQUAC of race, ethnicity, and language data as a start, hopefully moving on to disability, sexual orientation, and gender identity in the future. And then last, assembling a subgroup to develop recommendations on how to facilitate provider transition to electronic measurement. This is largely work that's done by staff, but involves the staff coming back to the task force, and this would be in the future coming to the SQUAC and sharing the results of the staff work, sometimes with members of the QMAT and sometimes the staff on their own, but coming back with findings and supporting discussion and debate and recommendations on action. Any concerns with having this work continue? Presumably in the future, this might become a squawk activity where the squawk might set goals.
Yeah.
But since we're sort of already in the flow for this year, are you all comfortable with the work continuing?
I'm not seeing any objection.
I'm not sure how to raise my hand, but
go ahead.
This is Ahmed. Could you elaborate on what you mean by number 5? What does that mean?
Sure. So, Ahmed, there are some measures, including 2 of the measures in our core set, the blood pressure control and the blood sugar control, that from the earliest days of HEDIS have involved getting a sample of patient records out of an EHR to assess what performance looked like. It's a highly laborious activity. Early on, that was a review of a sample of paper records. Now it can be a review of EHR records. The new approach to doing this type of measurement is to have provider organizations send data directly from their EHRs that contains lab values, blood pressure readings that are directly used to measure performance for the entire patient population of people with hypertension or with diabetes, as opposed to the more laborious sampling of selected patients. However, that sounds way more efficient and less burdensome. I think we've found that it is difficult for provider organizations, especially ones like Mark Mandel's, that have practices that can be on 10 or more EHRs, to get them to capture the data the exact same way and to transmit it to produce a measurement that produces a rate that's equal to what happens when you do the more labor-intensive sampling process. So it's really to think about how do we support data collection and data transfer from the practice organization to the payers, either through an intermediary or directly, to facilitate this transition, because the national measure stewards, and especially CMS and the National Committee for Quality Assurance, or NCQA, all of their new measure specifications are for electronic measures. But our provider organizations are going to fail on those measures because they don't have the data infrastructure right now and the data flow processes to support good performance. Mark, you want to expand on or improve upon what I just said?
Yeah, I'll just offer a couple other angles on that. So one of the ironies of NCQA's move to electronic clinical data standard, or ECDS based measures, is that if you wanted to do as well, let's say on one of those blood pressure measures or on colon cancer screening, which is kind of 10-year look back, so there's usually a lot of additional screening events that are detected on chart review. If you wanted to do as well on that in the absence of clinical data exchange, which we generally do not have within the state between payers and providers, you have to move from sampling a few hundred charts to sampling all the charts. So you move from a small chart review, which is burdensome, to a 100% chart review, which is extraordinarily burdensome. Clearly an unintended consequence of the change to electronic data review, but that's the short-term solution. Unfortunately, absent some progress on goal number 5. The other thing, Dr. Mullen put in the chat that this is a critique that's come up at QMAT of the current blood pressure measure, that there's no credit for lowering systolic blood pressure from 165 to 145. That's absolutely true. There is another related measure that CMS developed. It has sort of HEDIS type flavoring, although it's not a HEDIS measure itself, that does give credit for that. But in order to operationalize that measure, we need more frequent data sharing of blood pressure values than we currently do for the existing measure. So again, that's held back by the absence of progress on number 5 here.
Thanks, Mark.
Silva?
Yeah, I just have a question about the intent of number 5. I know NTQA is pushing to end hybrid measures for measurement year 2029. Is the intent of number 5 that we're looking to speed that up even further to 2028? Or are we looking to align with NTQA's timeline?
We're just trying to figure out how to help providers.
Okay, thank
Yeah,
you.
yeah. It's not really specifically in response to an NCQA timeline as much as it is in response to an overall pressure to move towards electronic measures.
Yes, thank you.
Thank you. I'll just share, with all of this, and Michael said, a lot of this work is being driven at the staff level. Michael Caljo, Andrew Jackma, and I, and our respective agencies are all committed to continuing to staff and support all of this work. We do think that there's a tremendous value here and want to keep the momentum going on this work. And Mark, you mentioned, some other, related work that has been of value. We're committed to putting the resources behind it to continue to make this a robust process, including having expert facilitation by you, Michael, and expert advice. So I just want to share that commitment with all of you. I do want to just share a perspective on these goals. And specifically, my strong recommendation for the QMAT on goal number 1. As I said before, I really do think that having the QMAT run through this process is the only way that we're going to be able to have a recommendation in a timely way this year. But I would really encourage the QMAT, as you're putting together your recommendation to the SQUAC, to really consider opportunities to strengthen alignment. And I can think of opportunities that could be both reducing the number of the menu set, as well as increasing the number of the core set. As I think about this, this aligned measure set is going to be in place for 2 years. We're not going to have another opportunity to look at this until 2028. And so I think this is an important opportunity to think about alignment, and would just encourage the QMAT, as you're going through your process, to think about those opportunities. And I think those are that's a perspective that I've shared with Michael Caljo, and he agrees with me on that. And I think it's a perspective that the Commonwealth as a whole is really thinking about opportunities. So that's my perspective, and wanted to share that with this group.
Thanks, David. Any other questions or comments on these 5 goals or what David just shared? All right, David, I'll transition to you.
Great. Well, thank you so much. I think this is really just been a meeting around kind of level setting and really about introductions to each other. I think part of our work moving forward is going to be, both making the recommendation for this year, but really about making a strategic plan for the SQUAC over the next 2 years, and what our goals will be, how we're going to implement those. And so we didn't have all of that work done for this first meeting, and really wanted to do that work with all of you and to have an opportunity to think through that long-term plan with you and to get your input. So I am, happy to open it up for any final discussion in terms of your priorities and goals. But just know that really looking forward to this work, and happy to kick off this work with all of you. Elizabeth.
And what are we thinking of in terms of a meeting schedule?
So I think for, as Michael said, the contemplation is quarterly meetings. I think we'll definitely need a meeting in April to consider the recommendations. We may need, depending on if there are areas where we're going to go back or ask the QMAT to make some modifications, we may need to add a meeting shortly thereafter. We'll see how that process goes. I think quarterly is probably going to be how we're going to proceed. However, the QMAT had been meeting monthly and making a lot of progress monthly. And so, I guess I want to kind of take that back a little bit and talk to Michael, and also as we think about what the new technical advisory group that we're going to be procuring and how often they'll be meeting and how often we may want to meet with them. So not a very satisfactory answer, Elizabeth, other than to say, I think we will have to think about this, especially in this transition year.
Can I add one thing to that?
Yes, Lisa.
Before we jump to Mark, just want to also note that, so obviously about half of this group are current QMAT members. Members of this group are absolutely welcome to, nominate to participate on the technical advisory group as well, generally, because of this transitional time and the way that the current QMAT was openly procured. Right now we can't add new members, but in an ongoing capacity, I think we do sort of see the groups have different expertise. Perhaps, there's a larger group on the QMAT, as Michael had noted, and if one were open to participating in more meetings and being in both bodies, that will be an option.
How do we nominate ourselves for the technical committee, if that's appropriate, or nominate someone else? Do you want us to?
Yeah, you can either one, and that'll be a future process. So similar to how through the QMAT, we did an open procurement where we, we reached out and anyone could nominate themselves, and there's a review committee. We'll do an open procurement for a technical advisory body that this group decides to appoint. For now, because of the timing and the overlap, QMAT as is going to be that technical advisory body through this initial recommendation. And then this summer, we'll do an open procurement specifically for a technical advisory group to support the SQUAC. And that will be open to all, and members of the SQUAC may be on that body as well.
Mark, you have a question?
Yeah, just a quick comment that as somebody who is actually on the front lines practicing primary care, I just want to emphasize how critical this work is in terms of reducing the administrative burden for primary care doctors. Barbara can certainly vouch for that. Again, the primary care task force, I think, is doing some great work around supporting primary care through resources, but there's still the administrative burden of actually trying to meet all the requirements that primary care doctors have. And so I think this work that we are doing around aligning the quality measures is a really critical piece of reducing the burden on primary care. If we are ever going to get new physicians into primary care, we need to reduce the burden on them, and we need to support them with the resources that are really needed so that they can actually provide access and quality patient care. Thank you.
Thank you very much, Mark. I agree. Barbara.
I would totally agree with Mark, and I would, for those of us who are practicing clinicians and both pediatricians and adult internal medicine, what we've often experienced in the quality alignment task force is that what sounds like a really good measure on paper, that is something that is really important to measure, is something that is not clinically easy to measure, not easily clinically record, and not something you can easily get from a data point in the electronic record. So whatever we do, and whoever is on both the technical committee and this committee, we need to be sure that we have clinically active physicians who can really relay the difficulties and the pluses to some of the measures, because some of the measures work and some of them don't. And so having people who are on the front line will make the judgments that we have and the decisions we make to be much more valuable and useful to really improving quality.
Thank you so much, Barbara. Dan?
Yeah, I'm just pleased to hear that others in the group share my thoughts that hopefully we'll take seriously the potential for harms associated with poor decisions about measurement, because I think historically those harms have been underestimated.
Thank you. Well, thank you, committee members, for this first meeting. Thank you for the members of the QMAT who are continuing on in this work and for your continued public service. I think as the previous speakers just articulated, a really incredible opportunity, an important opportunity to make some really important progress, both for providers who are struggling with the administrative burden, but also for patients who want to see better patient outcomes. And so I think we'll keep all of those perspectives in mind, as well as be informed by the really technical details that go into this. And so I think this is a perfect group to be able to move this work forward. I'm excited to learn from all of you and to work together on behalf of the residents of the Commonwealth. So if there are no further comments, I think we can adjourn this meeting. Andrew, did you have any final comments?
Echo your thanks and appreciation for everyone's sort of thoughtfulness and willingness to help really carry this effort forward. And looking forward to seeing you all in April. I'll be here very soon.
And some of you will be meeting before then. And thank you. All right. Thank you. Meeting is adjourned. Take care, everyone.
Bye-bye.
Thank you.